Welcome to Healthcare AI Weekly, the show where we break down the latest research at the intersection of artificial intelligence and clinical medicine and translate it into something you can actually use. I'm Raphael, a healthcare domain expert and solutions architect, and every week I dig through the newest papers so you don't have to, and I try to make sense of what they actually mean for patients, for clinicians, and for the people building the next generation of health AI tools. If that sounds useful, take a second to hit like, subscribe, and tap that notification bell so you don't miss an episode. It genuinely helps more people find the show, and it means I can keep doing this every single week. All right, let's get into it. This week we have two really compelling papers to talk about, and they share a thread that I think is worth pulling on. Both are about AI detecting conditions that current methods miss, catching them earlier or more accurately than the tools we've been relying on. First, we'll look at a blood-based AI test for kidney cancer, renal cell carcinoma, that uses metabolomics, which I'll explain, and post some strikingly good numbers across multiple hospitals. Then we'll turn to a completely different application, using video and computer vision to detect delirium in hospitalized patients, a condition that affects millions of older adults every year and is shockingly underdiagnosed. Both papers ask the same fundamental question: can we do better than what we've been doing? And both come back with a hopeful answer. Let's dig in. All right, paper 1. This was published in European Urology, one of the top journals in urology, with an impact factor around 25. So this is a high-profile venue. The paper comes from a large multi-institutional team led by Huang, Wang, Yuan, and colleagues, and it's titled Development and Validation of a Novel Plasma Metabolomic Signature for the Detection of Renal Cell Carcinoma. So let's talk about what they built and why it matters. Renal cell carcinoma, kidney cancer, is the most common type of kidney cancer in adults. And here's the problem. Right now, there is no effective blood test or lab screening test for it. None. Kidney cancers are often found incidentally. Someone gets a CT scan for back pain or a kidney stone, and there it is. By the time someone has symptoms like blood in the urine or a palpable mass, the cancer may already be advanced. And when kidney cancer is caught early, stage 1, 5-year survival rates are above 90%. When it's caught late, those numbers drop dramatically. So early detection is everything, and right now we're not great at it. What these researchers did was turn to metabolomics. That's the study of small molecules in your blood, things like amino acids, lipids, and sugars, that reflect what's happening in your cells at a metabolic level. Think of it like this. Every cell in your body leaves a chemical fingerprint in the bloodstream, and cancer cells leave a different fingerprint than healthy cells because they metabolize nutrients differently. Metabolomics tries to read those fingerprints. They used a technique called mass spectrometry to profile the plasma metabolomes of patients with and without kidney cancer, then fed that data into a support vector machine. That's a classic machine learning algorithm that finds the optimal boundary between two groups, in this case cancer versus no cancer. The result is a model they call RCAID, Renal Cell Carcinoma AI Detector, and it uses just 7 metabolites to make its prediction. 7 molecules in your blood. Now here's where the numbers get really interesting. They validated this model across 6 independent cohorts, meaning 6 separate groups of patients from 5 different hospitals, totaling 1,680 people. These weren't patients from the same hospital they trained on. And the AUROCs, that's the area under the receiver operating characteristic curve, which is essentially how well the test can tell the difference between someone who has the disease and someone who doesn't, where 0.5 is a coin flip and 1.0 is perfect, range from 0.911 to 0.988. Those are excellent numbers. For context, a lot of widely used screening tests don't come close to that. And perhaps the most important detail, 69% of the kidney cancers detected in these cohorts were stage 1. That means this test is catching cancers early, when they're most treatable. Let me put this in clinical perspective. If RCAID works as well as these numbers suggest, it could become the first effective blood-based screening tool for kidney cancer. Imagine it as part of a routine blood panel. A few extra tubes of blood, a metabolomic readout, and a risk score. High-risk patients get flagged for imaging. Low-risk patients get reassurance. It doesn't replace CT scans or biopsies, but it could be the trigger that gets someone to imaging earlier than they would have otherwise. And for a cancer that currently has no screening test at all, That's a meaningful shift. The fact that it generalizes across 5 hospitals is also significant. A lot of AI models in medicine perform well at the hospital where they were trained and then fall apart when you test them somewhere else. So multi-site validation is a real strength here. Now, let's talk about limitations, because there always are some. First, this is a detection model for one type of cancer, renal cell carcinoma. It's not a pan-cancer screen. Second, and this is important, the study is retrospective. The patients were already known to have kidney cancer or not. What we really need now is a prospective study, one where you test people who haven't been diagnosed yet, and see if the model catches cancers that would otherwise have been missed. That's a fundamentally different and harder test, and we haven't seen that yet. Third, metabolomics panels can drift. The chemical signatures can vary based on what someone ate that morning, what medications they're on, the time of day the blood was drawn, and even differences between mass spectrometry instruments at different labs. So the reproducibility story needs to be proven more rigorously before this goes prime time. But the foundation is strong. This is a paper worth watching closely. Hey, if you're finding this kind of translation useful, if it helps you make sense of a paper you might not have time to read yourself, take a second to hit that like button and subscribe. It genuinely helps more people find the show, and it lets me keep doing this every week. All right, let's get to paper 2. This one comes from PLOS Digital Health, published May 29, 2026. The lead authors are Mendu, Tesh, Pellerin, and colleagues from Massachusetts General Hospital and Harvard Medical School. The title is Video-Based Detection of Delirium in Hospitalized Adults. All right, let me set the stage here, because delirium is one of those conditions that affects millions of hospitalized patients every year, especially older adults, and it is shockingly underdiagnosed. Delirium is an acute state of confusion. It fluctuates, it comes and goes, and it can be subtle. A patient might seem fine 1 hour and be disoriented the next. It is associated with significantly higher morbidity, longer hospital stays, and even increased mortality. And yet, we rely on screening tools like the confusion assessment method, which requires a trained clinician to perform a structured assessment at a single point in time. It is subjective, it is intermittent, and it misses a lot of cases, especially hypoactive delirium, where the patient is quiet and withdrawn rather than agitated. So what these researchers did is really creative. They mounted a small camera, a GoPro, at the foot of the patient's hospital bed and recorded brief video clips during routine clinical assessments. Then they used deep learning pose estimation. Think of it as AI that can track the position of a person's eyes, face, head, arms, hands, and legs in every frame of the video to extract what they call behavioral features. Things like blink rate, blink duration, how much the patient's eyes are open, head movement, arm and hand positions, elbow movement variability, and knee movement. They extracted 58 behavioral features from each video, summarized them statistically, and fed them into 4 different machine learning models. The best performer was a support vector machine, the same type of algorithm used in the kidney cancer paper, and it achieved an area under the curve of 0.79. Now, I want to be honest with you. 0.79 is not 0.99. This is not a slam dunk diagnostic test. But for delirium detection, where the current standard misses a huge number of cases and there is no objective continuous monitoring tool at all, this is a meaningful proof of concept. The model also had a negative predictive value of 0.92, meaning when it said a patient did not have delirium, it was right 92% of the time. That is clinically useful for ruling out. What really makes this paper stand out is the concept. We talk a lot about AI reading images, AI reading text, AI analyzing lab values. But using AI to watch a patient, to observe their behavior through video and detect a fluctuating neurological condition, that is a fundamentally different application. And it has enormous potential. Imagine a future where every hospital room has a camera that continuously monitors patients for signs of delirium. Not to replace clinical assessment, but to flag when a patient needs attention. The AI works in the background, watching for changes in blink patterns, movement variability, and alertness. A nurse gets an alert. This patient may be developing delirium. Please assess. That is continuous, objective monitoring for a condition that currently relies on someone being in the room at the right moment. And the researchers did something important for trust. They used SHAP, that is Shapley additive explanations, a method for understanding which features drive a model's predictions, to show that the most important features were clinically meaningful ones. Elbow movement variability, blink duration, eye opening, and knee and wrist movements. These are things clinicians intuitively recognize as signs of altered mental status. The model is not learning some invisible statistical trick. It is learning to detect the same behavioral signals that an experienced clinician would notice. Now, the limitations, and there are some significant ones. First, the sample size is small, 50 patients, 109 video recordings. That is a proof of concept cohort, not a deployment-ready dataset. Second, this was a single-center, Massachusetts General Hospital, and the patient population was predominantly white. We do not know how well this generalizes across different hospitals, different camera setups, or different patient populations. Third, the AUC of 0.79 is promising, but not yet strong enough for clinical deployment as a standalone tool. It is more like a screening flag than a diagnosis. There is also a practical concern. Cameras in hospital rooms raise real privacy questions. Patients and families need to consent, and there need to be clear policies about data storage, access, and use. That is a solvable problem, but it is not trivial. But the foundation is genuinely exciting. Video-based, continuous, objective delirium monitoring using AI. That is a new paradigm, and this paper is one of the first to demonstrate it. So what do these two papers tell us when we look at them together? On the surface, they seem very different. One is about blood metabolites and kidney cancer. The other is about video and delirium. But there is a deep shared principle here, and it is worth naming. Both papers are using AI to detect clinical conditions that current methods miss. Kidney cancer has no screening test. Delirium has no objective continuous monitoring tool. Both papers say, we can do better. And both are doing it by expanding the signal space, by giving AI access to data that humans cannot process at scale. The kidney cancer paper reads metabolic fingerprints across 7 molecules in blood. The delirium paper reads behavioral signals across 58 features extracted from video. A human clinician cannot simultaneously evaluate 7 metabolite concentrations across thousands of patients. A human nurse cannot continuously monitor blink patterns and arm movements for every patient on the ward. But AI can. Both papers are also honest about where they are in the validation journey. Neither has reached prospective clinical deployment. But both have multi-site or multi-validation evidence. And both are building toward the kind of rigorous validation that earns clinical trust. So here is what I want to ask you, and I really mean this for everyone watching, whether you are a clinician, a researcher, an engineer, or a hospital administrator. What is the biggest barrier to getting AI tools like these into actual clinical practice? Is it the validation gap? We need bigger, prospective trials? Is it regulatory? How do you get clearance for a camera-based monitoring system? Is it workflow? How do you integrate these tools into how nurses and doctors actually work? Or is it trust? Convincing clinicians that an algorithm can see something they might miss? Drop your thoughts in the comments. I read every one, and I think this is a conversation worth having together. If this episode gave you something useful, a new paper to look at, a way to explain AUROCs to a colleague, or just a reason to feel cautiously optimistic about where health AI is headed, please take a moment to like, subscribe, and share this with someone who'd find it valuable. It really does help the channel grow and keeps these episodes coming every week. I'm Raphael, and this has been Healthcare AI Weekly. I'll see you next time. Take care of yourselves and each other.